Good afternoon, good afternoon, everyone, and welcome to our CTSC seminar series. And I should tell you that Dr. Adelman is lucky to have the last one of the season. We'll start again in September. Today, it is my pleasure to introduce Dr. Jason Adelman, who will speak on patient safety research. Dr. Adelman currently serves as Associate Dean for Quality and Patient Safety at Columbia, Director of the Center for Patient Safety Science, Columbia, Program Director of the Patient Safety and Health Services Research Fellowship, and Vice Chair for Quality and Patient Safety in the Department of Medicine. Oh, it's terrible echo. And Associate Professor of Medicine in Biomedical Informatics at Columbia University. He's also the Systems Associate Chief Quality Officer, which is what he's really discussing today on patient safety and learning health, and has a huge grant with multiple institutions, including Weill Cornell, on that topic. I will not steal his thunder, but to tell you that he is very well recognized in the field, and he is one of the leading national patient safety experts from the Becker Hospital Review multiple times between 2017, 20, and 2023. And in 2022, he was the recipient of the Eisenberg Excellence in Mentorship Award from AHRQ and the Eisenberg Safety and Quality Award for Lifetime Achievement from the Joint Commission. He has more honors than I could begin to tell you within an hour. So with that said, I will turn over the lecture to Dr. Adelman. Take it away.
Thank you. Thank you for having me. It's an honor to be presenting today. I have no disclosures. Today I'm going to talk about why I'm excited to focus on patient safety research and why I think others should focus on in this domain as well. What problem should one address who's interested in patient safety research? How do you identify a particular problem to focus on? How do you find the outcomes for your study? Talk a little bit about if you're working on something in quality and safety, is it research or is it a quality project, and do you need IRB approval or not? And then I'm going to give some examples of patient safety research from my own background. So why focus on patient safety? This is that famous report, To Err Is Human, that came out in 1999. It launched the modern patient safety movement and said that up to 98,000 people die a year from medical errors in healthcare, making it one of the top 10 causes of death. And this report launched many of our current patient safety and quality programs, many funding opportunities, and many research to follow. And despite that, recently some reports came out to reassess where we are. They didn't do these kind of estimates of how many people die a year, but essentially they show that patient safety is still a very big problem. So what you're seeing here on the left is from the Office of the Inspector General from HHS that just came out with a report in 2022. They did a large chart review exercise and found that 25% of patients admitted to the hospital have adverse events, 12% serious, 43% were thought to be preventable, like errors that we could have prevented. And then last year, an article came out in the New England Journal from David Bates, who's one of my mentors, is the first author, and he found remarkably similar results doing another very large chart review exercise. He found 24% of admitted patients had adverse events and 9% were serious and 23% thought preventable. His particular project that was grant funded, he focused on the inpatient environment and the outpatient environment, and this New England Journal article is focused on the inpatient, but then this past year, he came out with his outpatient article in the Annals of Internal Medicine, and there showed there was 8.6 adverse events for every 100 patients seen in an outpatient office annually, with 17% being serious and 2% being life-threatening. And so I just share this to show that patient safety is still a problem and requires research. Now, if someone was interested in working in patient safety, what projects should they work on? Well, first, for those of you that are researchers, when we submit a grant, we are judged by the significance of the problem and the innovation of the idea. And I think that's just a good general rule of thumb, whether it's a grant or not. Like, we try to solve significant, meaningful problems that, in this case, may be causing a lot of adverse events. And we are in need of innovative ideas to try to get us some improvement. As you see, we're not moving fast enough in 25 years from that to ERA's human report to those articles I just shared. We still have a large number of adverse events in healthcare. So what projects should you work on? First of all, you can get your ideas, as I have, from errors in your own hospital. So many of you may, especially the clinicians, may be familiar with the term keep safe. That's actually an NYP, Columbia Cornell made up term, but it's essentially voluntary reported events. Somebody makes a real error in the hospital, and often after an error happens, we do a what's called a QA review, a quality assurance review, where we do a deeper dive. And if it's really significant and a patient was really harmed, we'll do root cause analysis. And we have tens of thousands of voluntary reported events across our enterprise each year, many hundreds of QA review, and more than 100 RCAs. And so there's lots of hazards that we identify in our own health system that are opportunities to find a research project. In fact, much of my research career followed one of these adverse events, and I'm going to share it with you later. But in addition to that, you can look for what are priorities of the health system. I have a T32 fellowship where I train doctors to be patient safety researchers, and I often try to pair interest of the fellows with hospital priorities. And I do that for several reasons. One is you could create a real win-win situation. For example, I had a fellow who's really interested in sepsis, and sepsis is one of the 10 NYP goals. And by the fellow focusing on sepsis, what the fellow gets out of it is, because it's a major NYP quality priority, there are project managers and data analysts already committed to that problem. So the fellow got data needed for his research and people to help with to try out interventions, and it was great. From the NYP hospital perspective, fellows that do my research fellowship, it's a 2-year program where they're 80% protected to work on research, and often they're attending. So this particular fellow was a critical care attending. So NYP got a critical care attending with 80% protected time to work on sepsis, a priority. So the fellow won, NYP won, and usually, if it's something that NYP is working on, it's because it's a national priority, which usually will mean there's funding opportunities and there's a big gap in the literature, and so everybody wins. You can also find projects by opportunities identified in the literature, and I'll share a little bit about that. And then look at what the funding agencies are funding, and I'll share a little bit about that. But this I feel strongly about, which is, I think people are most successful when, most importantly, they work on something that they are truly passionate about. I mean, if you want to seek a grant and get funded, you should be working on something significant. You should have an innovative idea. It should be something that the funding agency would be interested in funding. So all these reasons will help you score well on your grant and be selected for funding. But the reason why I say you need to be passionate about it is because sometimes research can be hard. Like in my early days, when I was a full-time clinician but trying to be a researcher, I had to write my grants before I saw my patients and on the weekends, and I had to have thick enough skin to submit a grant and get it rejected and submit it again and get it rejected. My first 3 grants were rejected, and many people I know would have been done, but my 4th, 5th, 6th, and 7th were funded. Like once I got there, and then I had success after that, and I learned by my rejections. But like it was only because I was passionate about the problem that I sort of, at least for me, sort of muscled through, developed that thick skin and the motivation to keep going and, you know, work the extra hours needed. As far as like the opportunities in the literature, just circling back to those 2 articles I showed you from the David Bates group at Harvard, in the inpatient focus one, 39% of the adverse events were drug event related, 30% surgery or procedure related, and 12% healthcare associated infections. In the outpatient one, it was closer to 64% adverse drug events, 15% healthcare associated infections, 14% surgical procedure. So just some idea of like where the literature is pointing, but maybe more important is this. I pulled this yesterday off the AHRQ website. AHRQ is the Agency for Healthcare Research and Quality, and sometimes the government talks about folding it into the NIH, but they act very much like a section of the NIH, meaning the funding process is the same, the grants are reviewed the same, but they're dedicated to focusing on quality and safety. And this is just a snapshot of the current funded opportunities. They have these general grants, R03s, R01s, R18s to spread. They have training grants, different K awards. Then there's one funding opportunity now on system-based approach to improve patient safety. There's 2 funding opportunities for outpatient primary care. There's 2 on diagnostic errors, a very hot topic right now. Making the wrong diagnosis or delaying the diagnosis. There's a whole bunch on healthcare associated infections. And then there's my area of interest, health IT safety. As far as this like general grants section, these are just broad. They're not very specific, but then you can look at, this is the list of special emphasis notices that have come out where ARC talks about things they're really interested in. And so anybody could apply for a general ARC grant, and you'll have more success if you are focusing on one of these areas, and you could just sort of like just eyeball these, and then of course go to the website after if you're interested. But you'll see patients with disabilities, equity, infections with antibiotic resistance, digital health, and so forth and so on, primary care. I mean, you could also, even if it's not listed here, there's a very long list of HRQ's priority on their website that just covers the breadth of safety and quality. So there's lots of opportunities to get funding for patient safety research. I personally have, I don't know, 5 or 6 grants from ARC and a couple from the NIH, but there's more safety and quality grants at ARC. What outcomes can you use for patient safety research? So first of all, those studies that I shared, all the ones that I showed so far, like from the Office of the Inspector General and the David Bates inpatient outpatient, they all use chart review. In those cases, they use what's called a trigger tool, where they find some triggers that might suggest medical error happened, and then they do a chart review to see if in fact an event happened. So the triggers are things like the patient went home and they were readmitted. Why were they readmitted? Maybe they had an adverse event, or the patient had an operation, came out, and then were readmitted for, went back to the OR 24 hours later. Maybe somebody left in a sponge or made an error. And so they use triggers to identify chart review, randomly select charts. But it's chart review is manually intensive. It's a grant. You have to spend some money to do a good amount of chart review, as those studies from David Bates were grant funded. Voluntary reporting errors. This is tricky because people use voluntary report errors as outcomes, but it's really problematic because it's very biased by reporting culture. So I'm going to share with you later a study that I did on wrong patient errors. And I use photos to help assess if a photo of a patient in electronic health record can help prevent orders placed on the wrong patient. Now, when I got the grant, I pointed to the only study that was working on this beforehand. That study had shown they did a before-after study, and they used voluntary reported errors, and they went from 12 to 3. And I pointed out that we don't know if that really worked or not, because they were asking people to report if they made errors. Before they had photos, they had 12, and then they rolled out photos, and then it went down to 3. Now, did it go down to 3 because they had photos, or did they go down to 3 because people were too embarrassed to report after there were photos that they made an error? And we are so subject to voluntary reporting that it's very hard to use as like an outcome. But people do use it, but it's problematic for that reason. It is a good source of ideas, though, for projects. So I don't really recommend it, even though it is used. What I like to use is automated measures. Now, these are a little trickier. I know the CTSC at Cornell, a strong part of the CTSC is Tom Campion at Cornell, and Tom is quite gifted at making measures and using data, and that happens to be my area of interest, and I'll share that with you. So if you can pull from electronic record data, you can do, as I've done, very large studies across the enterprise. It doesn't have the cost and labor of manual chart review. So just quick, like, I get asked this question a lot. You want to try to help prevent something that's leading to errors, and you want to know, well, is this quality? Do I need IRB approval, or is it research? And it's a common question, and it's a bit hard to answer. The guidance that we get from the government, from HHS, is through these FAQs, and they give some information. But what we've done, Cornell has guidance online that's available through the IRB, and I'm going to share it with you. Columbia has guidance that's slightly different, but very similar. And we're in the process of trying to reconcile it and have one like cross NYP, Columbia, Cornell guidance, especially because more and more we're doing quality projects that cross the enterprise. And we don't want to work on a project that Cornell thinks is research and Columbia thinks is quality, or vice versa. So we're trying to get on the same page. But this is the current guideline from Cornell. It's a really nice checklist, and it asks some questions. Is the primary aim of the project to improve care right now? And if you say yes, that's more towards quality. Is there sufficient evidence or acceptance for the approach? Yes. Are the proposed methods flexible? That's typical for quality projects, and so forth. You can see here, they want to know if there's funding. This is available if you just Google quality versus research. A couple links down, you'll find this very document, or you can get it through your IRB. Okay, so I'm now going to just share some real examples, and from my own experience as a patient safety researcher, just to give you a feel for what patient safety research really looks like. And my hope is that some of my work maybe will excite you and get some interest. Now, my research career, I'm sort of an accidental researcher. I didn't really mean to be a researcher. I was a physician and a patient safety officer and an operations leader. And then through my day job, I came across this case. And this case led to a project, and I found the project so incredibly interesting that I wound up like publishing papers and then seeking grants. And before I knew it, I was a researcher. And so it all started with this case. Forgive me, I'll just read it out loud. Mrs. X, an 87-year-old female, was admitted to a telemetry unit that does heart monitoring with a diagnosis of rapid atrial fibrillation, a type of arrhythmia. The day after admission, a first-year medical resident accidentally placed an order for methadone, which is a very powerful narcotic used for heroin addicts, 70 milligrams, which is a really big dose. accidentally placed the order for Mrs. X, but he meant it for another patient. Both patients were on this residence list in the electronic health record. Several hours after Mrs. X received this methadone, she was observed to be restless. She complained of being hot and nauseous. And shortly thereafter, she was found to be unresponsive, pulseless, blue extremities. Code was called. She was intubated and transferred to the ICU. So this was a order accidentally placed on the wrong patient. Now, I looked at the literature. Why do people place orders on the wrong patient? And I found that the leading sort of theory was what was called juxtaposition errors. You have two names on your list in the electronic health record. You mean to click on one and you click on the other. Now, I wanted to study, I wanted to solve the problem. And so I wanted to do an intervention in the electronic record, an alert saying, "Are you sure you're on the right patient?" But I wanted to evaluate it to know if it was going to work. If I was going to put an alert that would fire almost any time a doctor placed orders, that's a lot of alerts. I want to make sure it works. So I came up with a team with an automated measure that could help identify if somebody placed an order on the wrong patient. So we can use it to test our interventions. And so the measure looked like this. The idea was, if I, as a doctor, imagine I have patient A, and I place a couple orders on patient A, a hip x-ray, a urinary catheter, an antibiotic. And 5 minutes after I place those orders, I cancel them. And the very next thing that I do is I order the exact same things on another patient. Like the programmer I work with used to call it the oops query. Oops, I'm on the wrong patient. Let me retract that and order on the right patient. So it turns out across New York Presbyterian, Columbia, Cornell, that happens 10,000 times a year.
Jeez.
10,000 times somebody places an order, cancels it, and orders it on the patient. And the question is, well, are these retracting order events actually wrong patient errors? And so there are so many of them that we were able to set up a system where we would get reports every day, and we could call people in real time. "Excuse me, Dr. Adelman, I noticed you accidentally placed, or sorry, you placed a couple orders on patient A and then canceled them and ordered them on patient B. Do you mind IRB approval? Can I ask you a few questions?" And then ultimately, was that a wrong patient error? We called over 200 people and 80% said, yeah, it was a wrong patient error. And so we, that's a pretty good positive predictive value with over 10,000 of them and 80%. Now, these are all like, by the grace of God, you realize, oh gosh, I'm on the wrong patient, and you catch them. But like, so they're self-caught. But it's the ones that aren't self-caught where an elderly person gets methadone by accident. So our belief was, if we could do an intervention that would prevent these oops events, to give it a more professional sounding name, we call them retract and reorder events, then presumably we'd also prevent the ones that reach the patient. In addition to calling people, if those 80%, which was 170 people, when we asked them, why did you place the order on the wrong patient? And we got these different reasons, and you'll see 10% were juxtaposition, which is what we were reading in the literature, but 80% was something else. And that's something else. I've given a lot of talks on this subject. People sometimes think it's similar names, or it's small, the name in the record is small font. It was none of those things. The number one reason why people place orders on the wrong patient was interruption and distraction. We heard the same story over and over again. I'm admitting Mr. B. I'm ordering everything: his diet, his radiology tests, his lab tests, his med tests. It's a whole admission. And somewhere in between all those orders, I get a call that Mr. A is in pain. Can I order Percocet? So I switch to Mr. A, I order the Percocet, and then I get a phone call. I have a 5-minute conversation with a colleague, and then I go finish Mr. B's admission. But I forgot that just for a moment, I switched to Mr. A and ordered the Percocet. So the rest of Mr. B's orders go into Mr. A's record. That's the most common reason why. It's like we are, as clinicians, we multitask, we switch through patients, we get interrupted, and it's all a setup for, you have to keep all these things in your head. What was I doing? And you just forget exactly what you're doing. And those moments that you forget, you wind up on the wrong patient. And that was different, as I showed you, than what the literature had showed before. So this automated measure, wrong patient retract and reorder measure, became the first health IT safety measure endorsed by the National Quality Forum, NQF, which endorses all the measures that are used like in federal programs. And then we've been using it. I have a study now, for those of you that are clinical, before my grant, there were 0 photos across New York Presbyterian. Now there's over 1.5 million photos, and we're randomizing whether people can see the photos or not to assess if they really help prevent errors. I had done a study in the neonatal ICU. As I started doing this research on wrong patient errors, I learned that one place where there is a lot of orders on the wrong patient is the neonatal ICU. And a lot of people felt the reason why is because of what you see on the screen right here. This is, from a real electronic health record, that babies are often given a temporary name like baby boy or baby girl. And why is that? It's really because, first of all, parents don't always have the name ready to go at birth. And it's very easy when a baby's born and you have to create a new health record for that baby. Labor and delivery calls a meeting and says, Mrs. Adelman had a girl. That's all you have to say. And then admitting will make a copy of the mom's record, same address, same insurance, same everything, and just take mom's last name, Adelman, throw in baby girl, done. But you could see how this could be hazardous. You could have baby boy Jones, baby boy Johnson, baby boy Jackson. So in fact, we had done a study and shown that was exactly right. Like using the automated measure of wrong patient errors, we were able to show that there's many more wrong patient errors in the neonatal ICU than there are in the rest of pediatrics when children actually have their names. But then furthermore, we did an experiment. What if we get rid of baby boy, baby girl, and instead I wanted to name the children Cutie Pie, Buggy Bear, and the head of neonatology said to me, Jason, that is a great idea. You can't do it. You can't start naming people's children for them. And so instead of doing that, we said, well, what if we use the mother's first name? Mary's girl, Yvonne's girl, Linda's girl, to try to make it more distinct. So we did this, and we showed that this actually worked, that there was a almost 40% reduction in wrong patient errors. We were able to do this study because we had an automated measure of wrong patient errors. That's what made this possible. And so you'll see we got rid of baby girl Jackson, Johnson, Jones, and replaced it with Wendy's girl Brenda, and that really worked. And this, after we published the study, the Joint Commission, first they made a recommendation, but then they made it a requirement. Like it's now a national regulation that if you're surveyed by the Joint Commission, if for those of you who remember, a long time ago, they said we can't write QD anymore. Well, then they added, based on our research, you can't use baby boy, baby girl anymore. And we had done a survey. If you see to the left, we had done a survey in 2013 to see what proportion of the country is using something like baby boy, baby girl. And it was in 2013, it was like 82%. We had about 40% of the NICUs responded and 82%. We repeated the study after the paper was published a couple of years later. We repeated the study, and you can see the results there. It went from 82% down to 70%, but that was 2018, 5 years after 2013. This is now 2023, and it's 5 years later. I just completed another national survey, doing the same exact survey, but the difference is now the Joint Commission requires that you don't use baby boy, baby girl. And so I haven't yet published the results, and we're just finishing the analysis, but I could tell you it went from 10 years ago, 82%, to after the paper, 70%, to after the Joint Commission, 10%. So the problem has almost been eliminated based on, like, first our publication, then the Joint Commission adapting it as a regulation, and the Joint Commission being a very influential, regulator, almost zeroed it out. Now, we were still worried that even if you use the mother's name, like Judy's Boy 1, Judy's Boy 2, at Cornell and Columbia and many of the academic medical centers, there are a lot of twins and triplets in the NICU. And so even if you use the mother's first name, you could have this problem. Judy's Boy 1, Johnson, Judy's Boy 2, babies are born together, so the medical record numbers for most hospitals that give them out sequentially are almost identical. Like, everything about these two babies is almost identical. And so we used, again, our automated measure of wrong patient errors to look at, even if you use the mother's first name, we used all the NICUs at Columbia, all the NICUs at Cornell, and all the NICUs at Montefiore Einstein. We partnered with them and showed that it's a problem, that compared to singletons, twins have almost double the wrong patient errors, even with the safer naming convention. And then triplets and high order multiples have double that of twins, quadruple. And so it's a problem. To help solve that problem, we got a grant from the NIH. I mentioned that we're doing a study if photos could help wrong patient errors, but we really didn't think photos of these little babies would help make a difference. So instead, we assign what we call pictographs. And so in EPIC, right now at Cornell and Columbia, this is what EPIC looks like, but this is where typically a photo would be. Instead, there's a blue whale, like a mom picks out. We had a professional artist draw like 400 of these things, all child friendly. The mom picks it out, and then so there's only one blue whale in the Cornell neonatal ICU at a time, and often these babies are there for weeks, if not months, and very soon everybody knows that the blue whale is this particular baby. Often when the mom picks it out, they tell a story why they picked out the blue whale, and it's a very cute story, like the father loves fishing, and then everybody remembers the blue whale is this kid. And so we don't have the results of this yet, but I'll tell you, when we were in the very early days of the grant, I got a call that at New York Presbyterian we were having the first set of quintuplets in 20 years. We had them 20 years before, and could I do something about it? We hadn't yet started the grant, but first of all, I met with the mom when she was still pregnant, with a translator and with the head of OB, and I asked if she picked out the baby's names already, and she had. And so I had said, let's use the baby's names so we don't have, every baby that you see on this picture here, each baby, when they born, the plan was each baby was going to have its own nurse right out of delivery, its own nurse, its own anesthesiologist to intubate the baby, and its own neonatologist. So there were going to be 5 teams with 3 clinicians, and the teams were going to be team 1, 2, 3, 4, and 5. And then she told us the names you see there, Sebastian, Sophia, those were the names. So we changed it to Team Sebastian, Team Sophia, Team Mateus. We gave them all pictographs. And you can see there's a picture there of like the bassinet with the picture of Sebastian and his name, and he was the baseball. We had little onesies made for them, and I'm very happy to report that there were no wrong patient errors, no retractable reorder events, and then the Post actually picked up the story. This just happened to happen right around Mother's Day, and it was like a nice Mother's Day story. I also did a study. A lot of people have been concerned that having multiple records open in EPIC, the way you can have multiple browsers open, leads to wrong patient errors. In fact, there was a national regulation. You shouldn't really have multiple records open and restrict to one. And I wanted to get a grant to study this because I wasn't convinced it was true. And to help get the grant, I first did a national survey, and I asked chief information officers and chief medical information officers, I asked, how many records does your electronic health record allow open? How many do you choose to have open and why? And it was really interesting. 42% of those that could have multiple records open said they allowed the maximal records open. And they said providers need to multitask. It's important for them to have multiple records open. But then 41%, almost the same amount, restricted just to one record. And they had said they were concerned about wrong patient errors, or they experienced the wrong patient error, and they thought that was the problem. And then 18%, I say hedged, meaning like they weren't really sure. They literally wrote in the survey, we think providers need to multitask, but we're worried about wrong patient errors, so we elected for 2. So we randomized providers across the health system, where half the providers were allowed to open the maximum records of 4 in Epic, and half were restricted to 1. And we showed that there was no difference in wrong patient errors. This was published in JAMA a couple years back. No difference in wrong patient errors in the emergency room, inpatient, outpatient, labor and delivery, peds, critical care, anywhere. In the ED, the odds ratio was literally 1.00 with a P of 0.96, like really no difference. So then I got another grant. I said, I think I can make more automated measures like the wrong patient measure so we can prevent more significant problems like doctors prescribing the wrong dose or the wrong route. And the general idea was that if you think about all the orders placed, if an order is placed and canceled within, let's say, 30 minutes, why would you place an order and then cancel it shortly thereafter? Maybe because you made an error. If you then order it on a different patient, that would be a wrong patient error. But what if you change the dose? What if I order 5 milligrams of morphine on patient A? Instead of switching to patient B, I cancel it and then I order 1 milligram on patient A. Or I order it PO and then cancel it and order it IV. Or I order it 3 times a day, cancel it and order it once a day. And so it turns out across New York Presbyterian, there are 21 million orders a year and 385,000 are canceled within 30 minutes. We called a lot of these people, and the majority, also about 80%, said they were in fact errors, and over 100,000 are reordered. That's all orders. If you look at just the meds here, 5 million meds ordered, 259,000 are canceled within 30 minutes. And if you see this number, 85,567 are canceled and then reordered. And if you remember this number is on the bottom here. 85,000 are a med is ordered, canceled within 30 minutes, and the same med is ordered back on the patient, but the dose is changed 20,000 times. The frequency has changed 12,000 times. The route has changed 5,000 times. So we made these measures and we made phone calls. We called 270 people that changed the dose, and 76% confirmed, yep, it was wrong dose error. 151 people changed the frequency and 86% confirmed, and so forth. So we have these measures, and then those that confirmed it was an error, we then asked them why they made the error. And we use this taxonomy of errors, looking at the highest level, there's mistakes, which is a mistake is you have the wrong plan in your head. So imagine an intern just doesn't know exactly how to dose an antibiotic, or they don't know that this is one of those antibiotics that you adjust for kidney function or for weight. And so the plan in their head is the wrong plan. That's a mistake. And then you can further break it down. Was it a knowledge deficit, or did they forget to follow a rule? But then at the highest level, mistakes, they have the wrong plan in their head. A skill-based error is they have the right plan in their head, but along the way, they wind up making an error, like they hit the wrong key or something. And so at the highest level, when we look at on the left top here is wrong patient errors. 97% of wrong patient errors are skill-based errors, meaning they knew the right patient, but they wound up getting interrupted and being on the wrong patient. But dosing errors, 73%, they have the wrong plan in their head. And so we have so many of these we can start looking at. When you get tired, do you start making more dosing errors, which are planning errors, or more skill-based, which are execution errors? So I'm just going to summarize my personal research, and then I'll wrap up the whole thing, and I'm happy to take questions. In my research, what I've learned is automated measures like the retract and reorder measure is a good way of identifying errors and makes research that wasn't possible before possible. You couldn't do my large randomized trial across NYP to study if photos could prevent wrong patient errors without an automated measures of errors. It also allowed for people thought juxtaposition errors like were the reason for wrong patient errors, but once we had an automated measure and could call people an hour after they made an error and ask them why, we learned like that wasn't actually the right thing. It was really interruptions. And so RAR measures allowed these kind of studies to occur. They allow for real-time interviews so we can discover, asking someone what happened. Imagine somebody a surgeon nicks an artery, and 20 minutes after it happened, there's a booming voice in the operating room. Excuse me, Dr. Adelman, I noticed like you had a technical error there. What happened? Like you usually can't interview someone so shortly after they made an error. We made the first automated measure like that, but now we're making many more and continue to make radiology measures and others. And there's potential to make even more. So I'm just going to end with why focus on patient safety. I think it is a very interesting area of focus. It's incredibly important. Patients should be able to come to the hospital, get the incredible care that our providers can provide without accidentally getting an adverse event, a medication error, a surgical error, other kind of error. There's lots of opportunity for funding, lots of gaps to fill. And so I encourage everyone to think about it. And I'm very happy to take questions.
That was excellent, Dr. Adelman. I have a question. Does your system, suppose an intern comes on in July and he's giving digoxin to a patient who is in heart failure, and instead of giving 0.25, he orders 25, and that order goes in. Will you catch that order within any time frame, or will the patient get that dose?
So I don't know. We do have like max alerts, like a pop-up might come up and say, this is too big of a dose. But unfortunately, we have so many alerts that we have a major alert fatigue problem, and sometimes people might not read it. Also, for dosing errors, or I should say medications, we have a system by which every order is screened by a pharmacist. And so if not caught by the alert, a pharmacist could call, but that is a good system, but also an imperfect system. And so we do have dosing errors. The more out of the norm the dosing error, the better chance someone will catch it. The final check in a medication is the nurse itself. Like an experienced nurse who's used to giving 0.25 knows we don't get 25. So there's a chance the pop-up will stop it. There's the chance the pharmacist will stop it, and ultimately there's a chance that nurse will stop it. But we do know that despite all those safety checks, errors still happen, unfortunately.
The other one that I noticed, I was asked to visit a relative who was recovering from a stroke and was being discharged. And the nurse was telling him, and I was standing there, about all his medications. And I noticed that the anticoagulant wasn't even there. The Coumadin was left off. He's post-stroke. He was about to be discharged without the one medication that he absolutely needed. Now, there's no way to to catch that, right? They're going out the door. I don't know how you would even develop something that would catch that.
Yeah, there are certainly high hazard points of care and transition, you know, med reconciliation on the way into the hospital. There are often errors, and then appropriately doing med reconciliation, making sure you prescribe all the errors on the way out is another hazardous. And as I shared at the top of my talk, like, we're still seeing so many errors. Like, we've been working on this since To Err Is Human, and we haven't solved these problems. I'm personally hopeful that, like, we're about to enter the age of AI, and where, like, the thing about healthcare is that it is still vastly reliant on humans, and humans make errors. There are other industries where, as technology gets more and more embedded into the system, that they become more reliable. So, like, we all have smartphones, and smartphones are 80%, 90% made by robotics, and only 10%, somebody snaps together the parts at the end. Or even an airplane, we often get compared to the airline industry, where the airline industry is a high reliable system. A large commercial plane can crash anywhere on the planet Earth, and we'll all hear about it, in the news. Even though it's scary when you fly, you hear about it. But at this point, the pilot and the co-pilot could fall asleep, and the plane will just fly itself. Like that's how much automation. We don't have that level of automation and error checking in healthcare, but it seems that we're getting there. So, like, you can imagine, a computer can see the prescriptions being written, can see what the patient was on, can read the notes and interpret it all, and then sort of figuratively poke the doctor on the shoulder and say, "Hey, did you forget the Coumadin?" And so I feel like we're heading there, and
Yeah.
the next 20 years hopefully will be better than the last 20 years in our advancement in safety.
Excellent. Any other questions? We could probably think of many of them, and I think if the physicians thought of things they did when they first came in as interns, they probably have many that they know about.
Everybody has a story like you shared with a family member. Everybody has made errors. It's there are just it's near impossible to provide perfect care. Um, Jeff, I see you have your hand raised.
Yeah, actually, I'm sorry, voice is a little off, but I actually had a question for you about I think one of the major concerns with a lot of physicians these days is sort of the huge drive to see more and more patients, to be more and more efficient, and the resulting sort of like burnout associated with that. Based on, I guess, your findings, have you found that that is playing a factor in medical errors at all? Just this like constant pressure that, more and more these days, we have being cost conscious hospitals are.
Um, I I I I personally have not, like, I haven't done research in that area, and I hear people speak about that a lot, but I'm not like an expert in the literature of that topic. Um, I believe it to be true. Like, that's a big theme. Another big theme is, like, uh, we spend so much time facing the computer instead of talking to the patient. Like, even, if you go for a checkup or you take your child to a checkup, and um, it's be and so I believe it to be true, but I don't know it to be true. We could theoretically, like, use my automated measure of errors to, like, ask a question like that, except for the fact that as you become attending, people place less orders and rely on the residents and PAs. But there are so I don't know the literature well, but I believe it to be true.
Yeah, thank you.
It is fatigue. Yeah.
Yeah, for sure.
I'm trying to. Any other questions? I had another one in my mind and I just I think what you did on the NIC unit is phenomenal. I mean, I never realized that that's where many of the errors were coming from, and that's scary. These are newborns, yeah.
Yeah, very.
So you did a really wonderful job there.
Thank you. Those are certainly patients that are very vulnerable to errors. Like they don't have a lot of reserve to tolerate an error. So it's an important area to focus on.
Yeah, and I think the other one, it's been a long time since I was marching around the wards, but the other one is when patients are put on Coumadin and they have to look at the numbers every day, and then they change the dose, and you know, these patients bleed and things happen, and they always seem to happen on a weekend, or there's no way to catch. Would you catch it with your system if something is really off in the reading of what the dose should be?
I've been focused on a few very specific types of errors, and the kind of my area of research lent itself for automated measures. I hope that we'll get to the point where we'll continue to develop all sorts of different kinds of automated measures of errors so that we can do a better job catching, like what you're talking about, the anticoagulant errors in general, and then are there more errors on the weekends, and like highlight or the other question, like the more automated measures we have errors, the more we can start seeing as you approach burnout. Like we could start seeing when people are starting to burn out, they're starting to make more errors, and maybe that's a time to intervene. And so we're not quite there yet, but similar to what I said before, I think our technology is rapidly getting better and will allow for more of that kind of stuff, and then we can ask those kind of questions of the data. So I think we're getting close to be able to do that, but not quite yet.
Well, you have made us aware that there are so many ways to make an error. You wonder that.
Yes.
That the whole thing is an erroneous and patient lives. Well, anyway, it is fascinating. We'll have to have you back again. Jason, this is a fascinating topic.
It was
And thank you very
wonderful.
much. It is.
Very accessible for the non-MD. Very nicely done. Thank you, Dr. Adelman.
Thank you. Thank you all for the opportunity. I'm happy to come back another time.
It's also frightening. I wonder also, is it related to the size of the hospital? Does anyone ever look at that? And the number of patients on a floor and the number of patients per nurse. There's so many things to look at that it makes me wonder why we get anything right.
Yeah, a lot of those questions come up in the patient safety world, and they're often hard to answer because you need chart review to look at errors, and people don't always report errors, and there's all these confounders, like the bigger hospitals also take care of the sicker patients. You're more
Yep.
likely to, have liver transplants at Cornell and Columbia than a small community hospital, but then they have more complications and complicated dosing and so forth. So some of these questions are just hard to answer.
Do you think AI will help with that?
I
or no?
do. I
You
do.
do, yeah. Okay, I think we'll let you go. And thank you so much. And I promise you'll come back and see us again.
I'd be happy to come back, and thank you again. Thanks,
Okay,
Thank you.
Emily.
thanks.
Congratulations.
Thank you.
Okay, thank you. Bye-bye.
Bye-bye.